Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. Our next case is a 48-year-old female with a newly diagnosed stage 2 left breast cancer. It's an invasive ductal carcinoma. Her disease is ER/PR positive, HER2 negative, and she is status post now lumpectomy. And we're wondering what would be the best adjuvant treatment for this particular case. So her pertinent history notes that she underwent yearly screening mammography, and this identified a new left breast asymmetry. She had no palpable disease. Again, excellent performance status. The description of her mammogram showed a lesion 4.7 centimeters posterior to the nipple, which measured 1.7 centimeters in size. And our ultrasound confirmed the lesion, measuring up to 1.9 centimeters in size. There was no suspicious lymphadenopathy. An MRI, again, showed an irregularly enhancing left breast mass compatible with a single normal left lymph node. I believe we have some images. Dr. Butler?
Yes, these are the two routine views from her screening mammogram of the left breast. And what we see here is that there's a mass at approximately 12 to 1 o'clock. This part of the breast is sometimes referred to as the apex on the MLO. And what we would like to see is that the tissue trails off with wisps that sort of imperceptibly blend into the retromammary fat. We do not want to see this kind of convex margin here that indicates an underlying mass. But that is, in fact, what we see in this case. There is a mass there seen in both views. And I think we can further see that in the MRI, approximately in the center of this image there.
Very good. So subsequent to a core biopsy revealing her carcinoma, she underwent a lumpectomy and sentinel lymph node dissection. The sentinel lymph nodes noted 3 lymph nodes recovered, one of which contained disease for carcinoma. Her disease, again, was ER/PR positive, HER2 negative, and additionally, she underwent an Oncotype DX score. So while presenting with a early stage lymph node negative breast cancer on pathology subsequent to her sentinel lymph node dissection, she was found to have a positive node. So she is a positive N1 disease. Starting with Dr. Mamounis, a 48-year-old with ER/PR positive breast cancer and 1 positive lymph node, do you feel as if she needs an axillary completion dissection?
No, I think that she's fine with the sentinel lymph node biopsy alone. I think based on the Z11 trial, she would have been a candidate for Z11 trial, which compared completion axillary dissection versus not for patients that had 1 to 3 positive nodes, 1 to 2 mostly. So I think that patient would have been a very good candidate for that trial. So I feel she doesn't need any additional surgery. And she had lumpectomy with negative margins, I assume.
Okay, so Dr. Shaw, how would you approach a patient like this? Clearly a younger woman treated with breast conservation, standard of care would be to use radiation for the breast, but as you're considering a positive lymph node, does that affect any component of your decisions, and what would be your recommendation for adjuvant radiation?
Yeah, so undergoing a lumpectomy, we would absolutely favor radiation. I think the biggest question is whether those fields would be whole breast fields or whole breast plus regional nodal fields. As Dr. Mamounis mentioned, the ACOSOG trial, allows for us to omit the axillary dissection. The AMAROS trial, which was the European trial looking at a similar question, also omitted the axillary radiation in one arm, axillary dissection in one arm, but allowed for axillary radiation. The trial was a little bit larger than the Z11 trial, and so we tend to favor that approach. And so I would recommend adjuvant radiation to the whole breast and to the lymph nodes rather than to the whole breast alone. In terms of dose and fractionation, the standard in this case would be 50 gray and 25 fractions to the breast, the axilla, the supraclavicular fossa, and the internal mammary lymph nodes. Seeing that she's 48, I would not favor hypofractionation, though it could be considered.
With respect to techniques, how do you identify the lymph nodes in patients to make sure if you're targeting them that they're included in the radiation field?
So when we want to identify the lymph nodes, the first part of that is what's called the simulation, which is a fancy word for the CAT scan. So at the time of the CAT scan, we will often have the patient use breath hold technique, particularly this is a left-sided breast cancer in a young woman. So we'll use that to pull the breast and chest wall away from the heart and lungs. After that, it'll be pulled over to our computer system and we'll draw out the lymph nodes. And we'll draw out the internal mammary lymph nodes for the first 4 interspaces. We'll also draw out the axillary lymph nodes and the supraclavicular fossa. And then when we plan the radiation, we'll ensure that we're getting coverage to each of those areas, meeting our constraints.
And are there cases that have positive sentinel lymph nodes and not a complete dissection where you would just target the level 1-2 axilla and not necessarily the supraclavicular fossa using what some people call a higher tangent technique, or including them in the fields that you treat the breast?
Yeah, so high tangents, meaning basically the top of your whole breast border goes within 2 centimeters of the humeral head, is a way to cover level 1 and 2. And so we typically consider that for either ER positive micrometastatic disease that's found in the lymph nodes, or it could be considered for 1 to 2 positive nodes that are having sentinel with macrometastasis and ER positive. It's perfectly appropriate to consider that for a Z11 or AMARO style patient.
And for Dr. Mamounis and Dr. Shaw, I know, Dr. Mamounis, you've published some data on Oncotype with respect to local regional recurrence. Can you tell us how the biomarker tests influence local regional recurrence? We'll be asking Dr. O'Shaughnessy later how it affects her treatment decisions.
So I think what we have found through a few studies that have been now published, both from our group and other groups, is that genomic profile and scores do correlate also with local regional recurrence as they do for distant recurrence. And we published an early paper with Oncotype DX for non-negative patients, finding that local regional recurrence was consistent with the different levels of risk based on Oncotype scores. We also published data for patients with positive nodes from an old NSABP clinical trial, the NSABP B28, that showed essentially the same stratification of risk with the Oncotype DX score. These were patients that had received also adjuvant chemotherapy. So it works both for patients that receive adjuvant endocrine therapy as non-negative, or adjuvant chemotherapy for non-negative patients, but also for node-positive patients as well. Now, what do you do with this information is not quite clear because obviously the general recommendation is to give radiotherapy for patients with positive nodes, even with 1 to 3 positive nodes. And what we found in the B28 study was that the Oncotype score did stratify patients with 1 to 3 positive nodes. The difference was not significant because the rates were low for all 3 subgroups of Oncotype DX. So it was in the range of the single digits, low single digits versus intermediate to high single digits. And because of the power, this subgroup was not statistically significant, but it was in the same direction. And I think that's a little bit of a disconnect also in general for patients that have positive nodes nowadays versus a few years earlier, where studies were done that were included in the overview analysis that showed significantly higher risk of local recurrence, even with 1 to 3 positive nodes, upwards to about 20%. We don't see these kind of numbers in the more modern clinical trials where we have data. We still see single digits. So you can sort of say, well, if you get the risk of local recurrence low to the single digits, would you affect distant recurrence and overall survival? And I think that's the debate, whether you can back off a little bit. Interestingly, there is a clinical trial now that actually tests the role of regional nodal radiotherapy based on the results that we and others have published. It's a prospective trial from the Canadian cooperative group for patients with 1 to 3 positive nodes that randomizes them to regional nodal radiotherapy versus not. So I think hopefully prospectively we'll get an answer to whether we actually get benefit when the levels of risk are low, as we now know, either by being more modern era and also based on the genomic profiling. This is for patients, the trial is for patients with a recurrence score of under 18 or less. And now there may be some amendment to go up to 22 or something, but the low recurrence score.
So Dr. Shaw, if this lady had concern about risk of lymphedema with her relatively low Oncotype score, would you feel comfortable with omission of regional lymph node radiation for her?
You know, it's a good question. Obviously, I think Dr. Mamounis alluded to the MA39 trial, which is looking at Oncotype and the consideration of regional nodal. I guess I would counsel the patient outside of that study, you know, particularly in someone who has a positive node without axillary dissection, you know, having limited nodal involvement is still a concern. And so I would recommend radiation and then highlight the low rates of lymphedema seen on the Amoros trial. Additionally, there was a recent study published of a little bit more than 5,000 women who had 1 to 3 lymph nodes involved that included Cleveland Clinic, Sloan Kettering, MD Anderson, British Columbia, and showed a relatively large benefit to the addition of radiation in this modern cohort of patients with 1 to 3 lymph nodes. So outside of the waiting for MA39, I would still, you know, advocate for lymph node radiation, understanding there is some risk of lymphedema in that situation.
Thank you. And finally, Dr. O'Shaughnessy, the really important question now about systemic management. Here's someone with the Oncotype as shown and a lymph node positive, and still relatively young person. What would be your approach for systemic treatment recommendations?
Well, she fits the criteria for the RxPonder trial, and we got the results of that long-awaited excellent trial at San Antonio this year. It's for patients with recurrence score 25 and under who are either pre or postmenopausal 1 to 3 lymph nodes positive. So what was found in that trial is that there was a 1.4% improvement in disease-free survival with the addition of chemotherapy to endocrine therapy in the overall treated population, because the patients were randomized to chemotherapy versus not, along with their endocrine therapy. But interestingly, all of the benefit was in the premenopausal population. There wasn't any benefit to chemotherapy at all in the postmenopausal population. Only 16% of the patients who were premenopausal, who were randomized to endocrine therapy alone, utilized an LHRH agonist, and only 3% of the premenopausals who got chemotherapy plus endocrine therapy utilized an LHRH agonist, because the trial was started before we had the results of the SOFT and the TEXT trial. As we do today, the standard of care has changed. So it really begs the question about whether chemotherapy benefit, which is about 5% absolute improvement in disease-free survival in the premenopausals, regardless of 1 node versus 2, 3 lymph nodes positive, and regardless of lower recurrence score, you know, like 12 and under or 13 and under versus 13 to 25, regardless of that, was still this 5% delta on disease-free survival. But is it really ovarian ablation that the chemotherapy is accomplishing? So we're going to be left with our clinical judgment. This young woman has a grade 2 breast cancer, low Ki67, very strongly ER/PR positive. So I would talk to her about optimal endocrine therapy, in addition to optimal surgery, radiation therapy, IV zoledronic acid. And I'd be comfortable with an LHRH agonist plus tamoxifen to start off with for several years, and switching her over to an aromatase inhibitor. I think it's a little bit easier to adjust to tamoxifen LHRH agonists with this indolent ductal biology. I think that would be quite reasonable. Or we could go with an LHRH agonist plus an aromatase inhibitor right away. But I would be comfortable foregoing chemotherapy in this particular patient, even though in the RxPonder data there was an improvement in disease-free survival. But I just think in a subset of patients with indolent, really ER-driven disease, it just had to have been because of ovarian ablation suppression from the chemotherapy.
Excellent. So in summary, the panel would recommend the addition of adjuvant radiation to the breast and regional lymph nodes with careful three-dimensional targeting and cardiac sparing techniques. And in addition, be comfortable with an approach of endocrine treatment in this with LHRH agonists coupled with either tamoxifen or aromatase inhibitor. And zoledronic acid is appropriate. Thank you.